Good evening, everyone, and thank you for joining us. This is Hussein Ghadiali, your host for this evening. Welcome to this webinar series, Advances in Neuroimaging, an Expert Talk Series. This is our fourth webinar in the series, and our topic for the day is Advanced Neuroimaging in Stroke, Tissue Window, or Time Window. This webinar is put together by InMed Prognostics Team NeuroShield in conjunction with GE Healthcare, and on their behalf, I warmly welcome you today, ladies and gentlemen. Without further ado, let me introduce our speaker for the day, Dr. Sweta Adatia. Dr. Sweta is an MBBS, MD, DNB Neurology, and FACP from USA, and she also holds an MBA from Cambridge University, UK. She's a specialist neurologist and a medical director at RAK Hospital, UAE. She's a whole brain master practitioner who's worked in Canada, South Africa, Middle East, and India. She's authored over 40 scientific publications and 2 books, and also many chapters in books for neurology and stroke. She's a TEDx speaker on the topic Impact of Stories on Brain. She holds a BA in music. She's an enthusiast of table tennis and spiritual speaking, and also is an avid traveler, having traveled over 30 countries till date. She's conducted over 200 workshops in various colleges and universities on using brain mapping techniques and helping hundreds of students choose the best career scientifically, easily, and with high accuracy. Our panelist for the day is Dr. Unni Krishnan. Dr. Unni is a doctor of medicine from the Angels University Foundation School of Medicine, Philippines. He has a graduation in medical imaging technology from the International School of Medical Imaging Technology, Secunderabad, India. He shares a passion for the healthcare industry and in bringing business elements to enhance the delivery of healthcare. His area of work and interest include medical imaging, patient counseling, practicing medical doctor, healthcare IT, PACS, medical device technology, entrepreneurship, and clinical healthcare consultancy. Before we start our webinar, a couple of things that we would like the audience to note. All participants will remain muted during the presentation, and we would request you to add your questions to the Q&A section. It will be addressed by Dr. Sweta and our panelist, Dr. Unni, at the end of the presentation. Thank you so much. And over to you, Dr. Sweta.
Hi, good evening, friends. I'm Dr. Sweta Adatia. I am a stroke neurologist and currently practicing in UAE. Stroke medicine is very, very dear to my heart. And so today's topic of acute stroke imaging from time to tissue window is a very, very important concept in today's world when we have a lot of interventional stroke units as well as stroke centers around the world. Thank you, InMed and Rajesh and Dr. Lata for inviting me for a very interesting topic. And let's hope that by the end of this session, we will have a very clear idea about what this whole concept or the paradigm shift in terms of time to tissue is all about, particularly in acute stroke imaging. So why this topic? Essentially, this is the right time to speak because we are, so to speak, in the tsunami of having acute strokes. If we look at the data globally, 1 in 4 adults above the age of 25 will have a stroke in their lifetime. I mean, that's a very huge number. So let's say if we are 30 of us here, just calculate the number of the people that may be afflicted by stroke. So this is of serious concern, and that is why we all have to take the acute stroke management very, very seriously. Now, if you look at the extended data, about 13.7 million worldwide would have a first stroke in particularly, especially in this year, which is 2021, and about 500,000 can also die as a result of acute strokes. And this is an exponential climbing thing, what is going to happen, and if we are not essentially curbing this thing by appropriate management. Of course, the preventive aspects are one very important key in terms of hypertension management or hyperlipidemia management, but what is essentially very important is what can we do when the patient has acute stroke, what best care in terms of thrombolysis, bridging, neurointerventional care that we can provide to these patients. So today in this series, we are going to see what is a stroke, why we should not stop just by simple imaging like CT scans or MRI. We will go and learn more about the time versus the tissue definition, particularly focusing on the penumbra. I'll share a few of my latest cases, which I've just had in my clinic, and we will conclude and wrap up with some of the interesting AI insights which we can have in the coming times, particularly in terms of neuroradiological evolution, so to speak, in terms of acute stroke, and particularly focus on the InMed, what they have been doing fantastic work in terms of AI and volumetric MRI. So coming to the stroke, and the serious concern about the stroke is that every single minute the cell count is diminishing. Now, if you look at this, it's a heartbreaking kind of the figure. So every stroke, we have 1.2 billion neurons which are lost. The brain is approximately formed of about 100 billion, where you just knock off about a billion in every single stroke. Now, if you look at the aging acceleration, which happens particularly in acute stroke, is about 36 years, and every minute a 1.9 million cell is lost. If we again calculate it further down in terms of seconds, 32,000 neurons are lost per second. So this is of concern. So I often tell to my colleagues that it's no time to drink a coffee. It's no time to evaluate any other thing. In particularly acute stroke cases, we have to quickly address, because every single second is crucial to the brain for its survival. Now, this is a very example. This is a great example from one of my colleagues in Canada, where I pursued my stroke medicine, where a patient has come at 1302, where the TPA bolus has been given. And if you look at the scan below, sorry, I'm going to show my cursor here. If you look at the CT angio, which is suggestive of a clot sitting at the MCA, middle cerebral artery, and then once you are giving the TPA bolus, this is the Doppler, vascular Doppler, which is suggestive of the MCA flow. And if you look at the picture at 1338, you have restoration or reperfusion of the vessel. So our goal in stroke is immediately to administer the thrombolytic agent without any delay, so that the perfusion can be restored and the tissue damage can be prevented. So this has been, so to speak, a very effective thrombolysis which has happened in this case. In such cases, the residual deficit from the stroke is going to be minimal. Particularly, you are looking into this is a left MCA, so potentially this patient could have had aphasia, right hemiparesis. So this can be prevented and avoided. So this is a very famous slide which all the stroke specialists love, because this is a pooled analysis from the NINS, TPA, Atlantis, as well as the ECAS and the Epithet trial. And the only moral of this trial is that the odds ratio for improvement is related to the time of treatment. The time cutoff of the treatment is essentially the very important factor in deciding the modified Rankin score, which is often used as a scale to determine the outcome in the patients with acute stroke. So if you want the modified Rankin score to be lowest, which means better outcome and recovery of motor output or outcome, this is what you have to do. Just essentially, the moral is time is brain. Now, we have evolved quite significantly when it comes to the administration of TPAs as well as management of acute stroke. When I was doing residency, I did not even have access to TPA. I mean, many years back, about 15 to 16 years back, that was the time when NINS TPA was just launched, and it was not available quite rampantly across the cities. But as the NINS TPA evolved and a lot of other trials took over, thrombolysis began to be quite expansive. Still, the global population who was being thrombolized was still low. ECAS 3 came in and said 3 hours, and then there was an extension where 4.5 hours. All this was great, and people were thrombolizing. 1 to 2% of the people were across the globe being thrombolized. But what was the game changer in the whole equation in the last decade, what you're seeing on the right side of the screen has been the evolution of the imaging. All the latest neuroimaging with all the MR, the ESCAPE trial, the Extend IA or SWIFT Prime, the availability of the advanced catheters, the wake-up studies, the diffuse, dawn, Extend IA. These are the studies from almost the last decade which changed the way we are managing the strokes now. So we have come a very long way from having just a time cutoff of 3 hours or 4.5 hours to something where time is fine. We just investigate and see if the patient can still have the thrombolytic agent or not. And thanks to these advanced retrievers, this is a clot retriever where you can essentially negotiate inside one of the branches wherever there is a clot, and pretty much you can remove the clots. Now, I have had patients back in Canada where we used to have Lazarus effect, which means the patient can have a very significant hemiplegia. You may have a very low power with a very high NIHSS scale, which is often used in monitoring the stroke patients. In those cases, once you are able to retrieve the clot with a very efficient neurointerventional team, essentially the patient goes back to being normal. Yes, you heard me right, essentially to being back to normal on the interventional table. So this is known as Lazarus effect. Essentially, you're just waking up being dead. Essentially, you have regained your full neurological deficit without having any outcome or in terms of residue at all. So this is, I think, essentially magical. This is the era where any sort of stroke neurologist would be happy to live in, because this is where we are making a big difference to the patient's life. So this is the beautiful chart which came across because of all these trials, that if you have a patient under 4.5 hours, well, give your IV TPA. You have a very high NIHSS score, let's say more than 10, and then the last seen normal is very important. If you still have it at 16 to 24 hours, you can do a CT angiogram. You need to go and follow the endovascular protocol. So if you have a large vessel thrombus, or if the patient has a wake-up stroke, you just do an MRI to look at the infarct core. If your core is small, you have a larger penumbra, you have a large vessel occlusion, potentially you straight away let the patient have the retrieval or thrombectomy. And if you have time, which is about just about 4.5, you still see a large vessel clot, you can do something called as bridging, which means you start the IV TPA and then go on to an endovascular suite or a unit where also thrombectomy can happen. So this is the fascinating sort of the world with endovascular evolution which has happened in acute stroke. So this is a nice paper of wake-up stroke where MRI guided thrombolysis has been done, particularly in patients who wake up where there is no time of onset of last seen normal available. Patients just say that when I went to sleep it was all fine, but when they wake up there is a deficit, and this is the time when MRI has been of great benefit. Even patients have been thrombolized based on the MRI wake-up trials, etc. and stuff, and patients have done very well in terms of outcome. Now, of course, thrombolysis beyond a period can have hemorrhage. About 6 to 7% has been also in the old NINS TPA or the ECAS trials. But the important message for the thrombolytic, any people who are here involved in the clinical care or giving thrombolysis is, it is equally important to understand when not to give thrombolysis, because this is very crucial. I think after having experience of thousands and thousands of thrombolysis, there is literally no worry for hemorrhage. But if the patient is wrongly chosen, then the chances of hemorrhage sort of increases. Or if the time and tissue window is not appropriately correlated, that can happen as well. So the whole idea or the fundamental physiology is essentially saving the salvageable tissue, which means whatever the tissue which is not dead, whatever the tissue which is called as the penumbra, where there is sluggishness of the flow, where the blood flow has there, but the tissue is yet alive, this is when you have to do all your perfusion or reperfusion strategies. The core is the dead tissue, where whatever amount of efforts that you do for recanalization or reperfusion, that's a dead tissue. So the idea in stroke medicine is to reduce the core, expand the penumbra, and then get the maximum benefit from the recanalization or reperfusion. I am a great fan of these advanced technologies, particularly the CT angio or the multi-phase CT angiogram, anything where you can have an added benefit to understand also the etiology. So stroke medicine is almost like mathematics. So you saw the infarct, you know where the infarct is coming from, you trace the vessel, you can also trace aorta, you can go ahead and do your echo stuff and all to know if it's cardiac origin. Once you know what is that, you immediately come to etiology. You can have atherothrombosis, atheroembolism, you can have from lacunar infarcts, from hypertension, etc. The whole sort of management is a very linear driven approach, and if you have the right tools, then life really becomes easy. And in terms of radiology, this is our protocol which we follow in the hospital in UAE. Is we do a CT angiogram along with MRI, just quick 2 diffusion and flare images for our patients who are having acute stroke. Even if we are not able to do MRI, for sure we do a plain CAT followed by CT angiogram. And if thrombolysis is required, we often thrombolyze in the CT suite itself. So we save time, but at the same time, we know where exactly the thrombus is lying as well. This is an example. On the right-hand side, you're looking into the MRI where a small infarct is being seen, which is early sort of the infarct. This is the time when you have to, if there is a deficit, this is the time when you have to go ahead and thrombolyze the patient. On your right side, you are seeing the yellow arrow, which is pointing to the hyperdense sign, which means that is where the clot could have potentially be lying. And if we do the CT angio, you beautifully see the filling deficit or the filling defect, which is the left MCA clot or a thrombus, which we are seeing. Now, if you look into the vessels, the distal branches as compared to your right and the left, you see that there is a paucity of vessels, which indicates what is the blood flowing across that region and segment. Again, this is the time when you want to go ahead and thrombolyze these patients. But if your center has some more advanced capabilities, I think multi-phase CT angio is it's not too complicated when it comes to radiology application of it. But clinically, this is something which can be of great help. So in the first half, you are seeing a patient with a left MCA, again, the yellow arrow pointing to it, with excellent collaterals. So if you look into the phase 1, phase 2, and phase 3, you have this hang up of vessels, which is essentially the backflow of the contrast, which is just lying out there. While at the same time, if you look into the second scan, again, the yellow arrow pointing to the right MCA, there is no backflow. Essentially, the tissue is absolutely without a couple of vessels here and there. This is poor collaterals. The outcome of the patients of reperfusion is very different if you have excellent collaterals versus poor collaterals. Now, this also means that a little bit of expansion of time window or tissue can be given to the people with good collaterals, because you know that the support from the collaterals is going to salvage furthermore that tissue. So this is a very important, easy to do sort of a test when you are attending a patient with acute stroke. Now, I am a great fan also of the signature patterns, because that leads us to the etiology. So I often go ahead and look very carefully into where exactly is the infarct, what does it look like, how does it connect to the periphery, what is the signature pattern like. I'm going to go through each of the infarct to say what I mean when I say signature pattern of infarct. So if you look into the first CAT scan, you see almost sort of a wedge carved across into the right hemisphere. Now, this is a classical cardioembolic type of the stroke, which you anticipate. So you have to do Holters. And in my experience, interestingly, if the one Holter has come negative, the second, the third, and the fourth Holter is what you do, because you have to essentially find out, I'm sure that if you chase enough, atrial fibrillation would be found. And that has an impact on your management, because then your anti-epileptics are of no use and you move on to your warfarin, etc., and stuff, the anticoagulations. Okay, so that is where it is very important. Now, the right corner, what we are seeing is a small dot, pretty much a lacunar infarct, which you see in people with atherosclerosis or hypertension, diabetes. So immediately, you know, you can correlate it to any of the underlying vascular risk factors. Now, if you look into the middle scan, which is scan number C, you see the dot or the chain like stuff pattern of the infarcts. This is a very classical pattern which you see in people with carotid artery blocks. So this is a hemodynamic kind of the infarct, where you can have shower as well as you can have flow, which is restricted, which is the reason why you get both an embolic, which you are seeing it here, as well as a chain of or pearl sort of a signature infarct in people with carotid blocks. So our job then is to not only just do a carotid Doppler, but also a CT angio of the head and the neck. Now, we have had patients who also had aortic thrombi. We have had patients who had actually thrombosis sitting right at the origin of the carotid arteries, and that also can help us determine the robustness of the thrombolysis or the potential for further thromboembolism, etc., in people with strokes. So we discussed a lot in terms of the imaging or the advanced protocols which we can use when it comes to acute stroke, and essentially that is just to determine that what can we do beyond the time window. So let me give you here the two concepts. One is time window, which is the standard concepts in the time of NINDS TPA that we have been following. The wake up MRI is also on the based on the similar concept. You do the MRI if you don't know the last seen normal because you don't know the time of onset. You look into the DWI or the flare mismatch if there is a DWI small infarct, but if there is a very big flare, which means already the tissue is dead, and which means it cannot be resalvageable or reperfused. Even after the reperfusion, the patient might bleed rather than actually be benefited. So no advanced facilities are available in the center. You cannot do it. Yes, time window is something what you should stick at 4.5 hours. You should definitely follow all the do's and don'ts of a typical thrombolysis. You should know all the relative as well as the absolute contraindications, particularly treat the high blood pressure or any of the things which you can have immediate access to in terms of your thrombolysis. But tissue window again is where you, if you have the perfusion scan, so where you can know the CBV or the CBF, the blood volume, the blood flow, as well as exactly carve out what is the dead tissue versus the salvageable penumbra. Use something like a rapid software where you can immediately gauge the exact time of flow and exact type of the infarct, etc. That's something very useful where you can step out and go beyond the 4.5 hours, and you can essentially still salvage the brain. If you have an access to endoscopy suite, this is very important because even at the border, even beyond 6 hours, 12 hours, people have thrombolized or thrombectomies have been done. Apologies, not thrombolized, but thrombectomies have been done until about 24 hours, particularly the posterior circulation. You have a big basilar clot, and then you do your perfusion scans, and you still know that the tissue is not dead to an extent. I think this is the time when you go ahead and use thrombectomy as your rescue. So Extend TP IA trial was a fantastic trial again, where patients were given a TNK or tenecteplase when it was the bridging protocol, which means one shot of TNK, and then the patient is taken to the cath lab or the cath suite to get an endoscopic retrieval of the clot. So this is essentially the moral that if you don't have advanced imaging, stick to the time, stick to 4.5 hours of thrombolysis, select your patient well. But if you do have the luxury, go ahead and do all the stuff where you can know pretty much the whole mechanism as well as the stroke area, etc. So these are the recently two published studies. It's not as recent, a couple of years have already passed by, where you know that even 6 to 12 hours, you can go ahead and look into the MRI diffusion flare mismatch, and also if there is a perfusion scan, you can go ahead and select these patients for thrombolysis. So I would like you to go ahead and read these MR Witness as well as Wake Up. I think they are great trials. Again, insisting the thing that it's not always about CT. MRIs have also been of great help, provided we do it in the protocol as it is prescribed. This is what I was talking about. You can extend it up to 24 hours, particularly if you do see that there is a mismatch. That is like a win-win in terms of the tissue, and you can thrombolyze it. Now, AI is going to be revolutionary pretty much in terms of stroke care. When we say that, yes, the core penumbra or the salvageable volume, collaterals, the time of onset of the stroke, and then the outcome of MRS. If there is one particular protocol or one sort of a software which is giving everything to the clinician, I think that is like the holy grail for stroke medicine. So you don't need to go assessing or analyzing the information that you have. You pretty much have everything on the software, which tells you get to know about the signature infarct, you get to know about the LVO status, the salvageable tissue can get mapped out, you can know the core, you can immediately relate the core to the outcome, particularly the MRS, and then you can back correlate again your NIHSS versus the MRS, and because you can now use machine learning algorithms to sort of populate these data and give a very confident review to the clinician as well as the patient, because finally you don't want the brain to bleed, you don't want the infarct to expand, you don't want the salvageable tissue to die, you don't want the deficit to expand, you don't want the thrombus to further lyse and create problems. So you don't want any of these things, and it's again essentially mathematics of it, that if you take all the steps right, then everything in the end definitely goes well. So all that is well that ends well is exactly what can happen in stroke. So thank you very much. I am quite grateful for InMed to have invited me for this very important seminar, and I shall be available for any questions, concerns, queries, etc. So that's NeuroShield, which is the volumetric MRI, which Rajesh and Dr. Lata has been developing, and the team is fantastic, and I think I am quite pleased to work with them as well. So thank you very much indeed, and I'm open for any questions. Thank you.
Thank you, Dr. Sweta, for that very stimulating presentation. Before we move to the much-awaited Q&A session, we would like to show the audience a video on NeuroShield. Yeah.
How often do you use your brain? At this question, most people chuckle or laugh, but the fact is we all use our brains all the time. Have you ever thought of your brain's health proactively? Almost never. Part of the reason is because we don't have reliable tools, which will help us manage our brain's health. So, we at InMed have come up with a solution, where we offer cloud-based clinical decision support tool for neurological disorders. NeuroShield is an artificial intelligence and machine learning-based tool, helps neuroradiologists, neurophysicians and psychiatrists understand the brain better and offer evidence-based diagnostics. The current challenges, which are operational and clinical problems. All the existing solutions addressing these problems are expensive, time-consuming, and don't provide contextual results based on age, ethnicity, and gender. NeuroShield, our solution, which combines the latest tools in medical and technological advancements. The common practice for doctors is to perform a neuropsychological assessment and ask for an MRI to help in diagnosing brain-degenerative diseases like epilepsy and dementia. But visual MRI reading can many times provide non-conclusive information, resulting in missed diagnosis. Our software, NeuroShield, makes it possible to look clearly at the region of interest, like hippocampus, compute brain volumes, and supported by cutting-edge research and imaging analytics, which can help physicians reach more reliable and conclusive diagnosis as opposed to the conventional method. NeuroShield is the platform that aggregates insights from relevant modalities to provide holistic health and wellness insights. These are some snapshots of the platform provided with the test reports and volumetric analysis. Our competitive advantage metrics are as follows. Our vision is to bring affordable, accessible, reliable, and evidence-based health prognostic tools in India and other emerging markets. Reach out to us and get to know more.
Doctor, we have our first question from the audience. Could you talk a little bit about thrombolysis versus thrombectomy?
Sure, Hussein. Thank you for that question. So thrombolysis is given as IV, intravenous. So you have alteplase, which you have to give within the first 4.5 hours, while thrombectomy is essentially via a retriever. So you can go and negotiate in the large vessel occlusion, particularly if you have a terminal ICA or a middle cerebral artery, that's where you can have the performance of the retrieval, and that's called as thrombectomy. So, and when you say thrombolysis, initially followed by thrombectomy, that is what is called as the bridging.
Thank you, Doctor. Dr. Unni, you have anything to add to that?
Yes, thank you, Hussein. Dr. Sweta, you have covered a vast subject like stroke in just 15 to 20 minutes. It was a great insight. So what when I say all the clinicians across take home from the presentation you have provided is that time is brain, and stroke is emergency, act quickly and faster. And I have a query, or from your past experience, there are presentations in the emergency room where the patients, or what we clinically call as the late presenters, how do we clinically approach them, and in hand with the radiology department, Dr. Sweta?
Yes, thank you, Dr. Unni. So we do have these sort of borderline where the clear 4.5 hours is never there. And unfortunately, despite so much of awareness, there is always a lag because the patient suffers this and somebody has to see that there is a facial droop or the weakness, and that's how come to the hospital. So often, always there is a delay. So how do we go about is, first of all the hospitals should have a stroke protocol or a stroke code. The moment the person enters the triage, the stroke code gets activated where the neurologist, the radiologist, interventional team, everybody is available. Even if there is no interventional team, the key players who are managing the stroke should be actually available there in the emergency to assess the patient. Now, in any case, if the time is not clear or the last seen normal is not clear, for example, the patient slept and woke up in the morning, doesn't know that when exactly the stroke would have happened. These are the times when I personally prefer to do an MRI and look into the diffusion and flare mismatch. Or if I have a perfusion scan or a software like Rapid, that's when that gives me a very, very confident understanding of how much is the infarct, how much is the core, is this the time to thrombolyze or no. This is exactly what is the tissue method that we're talking about. However, if the patient's last seen normal is also not known, it is always wiser to follow through with a CT angio as well as an MRI when the time is not clear. When the time is clear, absolutely 4.5 hours. If there is no contraindication, go and thrombolyze. We do a simple scale called NIHSS, so that it's a very, very, very simple tool. I think a clinician, if is very much aware about this NIHSS, any score beyond 4, which is considered as a significant deficit within the time window, that's when we thrombolyze.
Wonderful. Thank you, Dr. Sweta. Do we have any other question, Hussein, or should I go with the next question with Dr. Sweta?
Yes, we have a couple of other questions.
Yes, please.
So, in terms of artificial intelligence, we are having questions that in the future, is AI a do for all? Will all of the work done by the radiologist be done by AI? Your thoughts on that?
So I think Dr. Unni can answer that. Dr. Unni?
Yes. That is the question. All clinicians should be ready to accept. Wherein I always, in all my sessions, I speak about the disconnect between the imaging or the imagiology and the practicing physicians. That connect has to come in to merge in a place wherein we have all the database collected from the past experiences of stroke, which is not only just imaging, but also the clinical data coming from the physician, who at the end is the treating physician, who knows in and out about the patient who is undergoing a stroke as an event. Now, this data has to be collected and has to be cleaned in a manner that tomorrow, in one of the point which Dr. Sweta mentioned, that the time taken from what we say as from door to needle and taking the patient from a more unstable to a stable condition requires little more time for us to come out with more precise imaging and clinical outcome based data should integrate with each other. I think that day is not too far, but we have to work very closely.
Thank you, Doctor. Doctor, we have another question coming in. Could you please repeat on the implications of collaterals on therapy?
Yes, thank you for that question. I think I showed a very nice slide where if there is a potential presence of collaterals on a multi-phase CTA, the outcome is going to be far, far better than without the collaterals, which means the tissue gets enough perfusion. So the reperfusion, whatever you're doing, thrombolysis, or you're going to go do a clot retriever, the chances that the outcome for this patient is going to be quite robust, and this has been shown in the trial, and in fact it was one of the trials which the Calgary team had launched way back, but this has still remained quite a kind of robust. And interestingly, multi-phase CTA is not that difficult to perform if you have a radiology department where you can just train and perform some sort of protocol developments. This is super easy. So as a stroke neurologist, what I need to know is, can I save this tissue or not in this particular given time? And this is one of the markers for me to understand that yes, this is the tissue that I can save.
Hussein, I have a question to Dr. Sweta, because she's picked up the word the tissue window. I have a question. In the real-time clinical practice, how are you relying on the tissue window, that is your penumbra, as the primary point of focus to treat your patient and also follow up with imaging modalities?
Almost always, Dr. Unni. This is our stroke protocol. So every single patient has to have a perfusion, because back where I practice, we have a full stroke unit and everything is set up in terms of radiology. So time for us is a luxury if it's under 4.5 hours, but if that never happens, most of the time the patients come beyond the typical thrombolizable time window. And that is when the CT angio plus the rapid perfusion plus minus MRI is almost of help. And most of my decisions, even up to 18 hours, 20 hours, we had sent the patients, particularly for basilar or vertebral, for clot retrievals, even beyond the typical traditional time. So I think slowly over the period of time, it's all going to move away from time and essentially to the tissue and physiology. That's the future. And if AI is able to help us in that, I think coming back to the previous question, no, the radiologists are never going to be redundant. It's always the speed, the accuracy, which is going to be taken over by AI, but it's always going to be superseded by finally the human brains. It's just the efficacy or the efficiency would be far better going
The reacting
forward.
time of the physician.
That's
yes.
right. Yes.
Yes. You have another question, Hussein?
Yes, Doctor. Thank you, Doctor, for your insights. And in continuation with the previous questions on collateral, does that also increase the risk of reperfusion-induced bleed?
Again, that's a very, very good question, because you can, so what is the risk of giving a thrombolysis? Why you need so many tight protocols? And because of the risk of bleeding. If the tissue is dead, that is what you can have the bleeding. So the more you delay, the tissue is sort of going towards almost being dead, the chances of bleeding is very high. Chances of bleeding is also high when it's a cardioembolic stroke. The tissue is quite fibril. It's a different kind of the clot than your typical atherosclerosis clot. But no, There are no such studies which have suggested that the more number of collaterals means there could be a reperfusion bleed. At least that is what I am not aware about.
Doctor, another question. In your opinion, does TPA stand superior when compared to tenecteplase, streptokinase, etc.? Though many trials have been conducted, but there hasn't been any evident or strong data in this case.
Fantastic question. I think this is very important because we know that tenecteplase theoretically is far superior. It's fibrin specific, it's quick to administer, it's a bolus dose, while alteplase is not that fibrinolytic, fibrin specific. It takes about an hour for administration. So considering the use of tenecteplase in the cardiac world, we all have had ample experience. Tenecteplase theoretically should have been superior. Streptokinase is out of question because most trials have not shown any superiority of streptokinase. But let me share the latest paper. If Hussein, you can allow me to share, because this is very important. We need more randomized controlled trials. People have been doing tenecteplase. Tenecteplase has been used in acute stroke. So this is a very latest paper from Dr. Muir. Should tenecteplase replace alteplase for acute thrombolysis? There are a couple of trials like Extend IA or Attest 2. But what I'm going to do is I'm just going to read this. Sufficient data to support regulatory approval of tenecteplase as a global replacement of alteplase in acute stroke will come only from the ongoing randomized control trials, while some regions might opt to make the switch to tenecteplase ahead of the regulatory approval, because currently for most countries, alteplase is the only US FDA approved molecule. But yes, there is quite a big hope, and there is also some superiority shown in the trials which have been conducted for tenecteplase. So in future, possibly we would be talking about tenecteplase.
Thank you very much, Doctor. And we will be sending a link for this particular paper to all our attendees after the webinar has been concluded. Doctor, what is a deciding factor? Time or the size of thrombus for whether to go for thrombolysis or thrombectomy?
It's both. Both are very important because time will decide the friability of the tissue or the salvageable penumbra, and the size of the clot will decide if thrombolysis would be enough. So if there is a large ICA clot, or if there is a thrombus sitting at the terminal ICA or an M1 segment of the middle cerebral artery, possibly the thrombolysis might not be enough to lyse the clot and give enough reperfusion. So there are some ticky flows, etc. So enough perfusion would mean enough blood reaching to the salvageable tissue. If that does not happen, that is the time when thrombectomy or retrieving the thrombus is very, very important. Am I audible?
Yes, we can hear you, okay. Doctor. And so there is another question. What is the timing of the phases in multi-phase CT for cerebral angiogram after the IV contrast?
I would not know that because that's a very technical question. Yeah.
A technological question.
That's right. Yeah.
Right.
But it's not that difficult. That's what I understand. It can be very well done.
Yeah. Dr. Sweta, it is not a very hard task to relay the phases of the contrast which is study is done. Usually we do we call it as a chase of the contrast from the aortic arch into your carotids and your circle of Willis, and follow up with the venous phase and kicks in. It is all 10-15 years back it was too tedious, but today the artificial intelligence and the algorithms fixed in pre-calibrated into the CT multi-slice CTs, it is doing all the tasks with the press of a button. Even the automatic pressure injector is also taken care of. Everything is now very precise. The imaging is good. You are able to collect a lot of raw data, which the radiologist and also the neurophysician and the neurosurgeon can later on come into the console and virtually play with the data and see all the arterial phase, the venous phase, and look at all the MIPS and MPRs, and so that we get a 3D view of the blood vessels, of cerebral blood vessels, and be able to pinpoint on where is the deficit which is seen in the angio. Yeah.
Yes, Dr. Oni, I think this is the crucial thing. I think for any clinician, it's equally important to also know what is the cow like, and especially I like to do a head and a neck, because otherwise you're just doing half job, because you should know the proximal vessel potential. Is there a thrombus sitting there? What is happening? What is the signature pattern like? And it's not as complicated, because the 3D construction and from the raw images to the whole thing is pretty cool. It's like I think we can literally, the images are as superior. In fact, the specificity, I'm surprised, and I think Dr. Uni, this is something very interesting, that the CT angio superiority is as good as a conventional angiogram.
I totally agree. I had a fist-to-fist talk with one very senior cardiologist when he pinpointed me and said, Dr. Uni, do you think CT angio is superior to a conventional angio? Wherein I said, this is almost 6 to 7 years back. When I said, I was confident enough, I said 96% I'm sure the specificity of the scan is superior. And I don't have to go into an invasive methodology to screen a patient with very initial signs. I can get off with a less invasive CT angio. And if required, if I see a sign, then the cardiologist can go in an invasive procedure.
Absolutely. And I have done thousands of them in last about 10 years of my stroke practice, and none of them has any issues with the creatinine also, or anything to do with the dye. So we don't need to wait for creatinine and stuff. Of course, your elective practice is very different, but we are talking time here. Yes. So we don't essentially wait for none of the CBC parameters or anything. We just take a proper history, which is the key in terms of stroke care. Like history and last seen normal, I think potentially are two important quick things, and a very, very quick exam with NIHSS score can be enough to take the decision. I think what is also more important is when not to thrombolize, and all these things of imaging makes us to give that answer very, very, very succinctly. So imaging is like head on with your clinical judgment and decision.
Yeah.
Thank you, Dr. Sweta and Dr. Uni. Another question that we have is, in your opinion, if the patient gets blood clotting in his nervous system, what are the chances for the patient that the patient survives, and what steps can be taken to save the patient's life?
Not clear. Nervous system, are you talking about if the gentleman is a doctor or a non-doctor?
Saurav, may I unmute you?
Yes, you can ask the question directly, please.
Yes. Yes.
Yes, Saurav.
Sir, can you hear me, sir?
Yes, Saurav, please.
Sir, my question is simple, that if the patient gets blood clot in his nervous system, I mean to say his brain,
okay,
what are the chances that patient can be survived? Because my grandfather didn't survive for that case. That's why I'm asking.
So, Saurav, thank you for that question. It depends on the size of the clot, the type, where exactly it is, how much damage it has done, and what are the other factors. So high blood pressure, high sugar, what else is happening into the whole thing? What is the age like? What is the type of the stroke? So all these are multiple factors. So it's not that, okay, we give it thrombolysis in time and then the patient will definitely have a good outcome. The chances of the outcome is 33% better to not embrace a wheelchair or not be handicapped, but this is 33%. So very important is to understand the patient in toto, in completeness for the outcome. I hope this answers your question, Saurav.
Yes, ma'am.
Thank you, Saurav. Thank you, Saurav.
Sir, can I ask one more?
Yes, please. Please, Saurav.
Sure.
Thank you. Ma'am, what if I if the patient I see that his blood clotting, or in that case scenario, as the CT angiogram or MRI can give me the best result, or just average result for the patient condition.
A CT angio and CT brain, I think there is also a similar question. If an institution has no MRI in acute stroke, do you do CT angio or CT perfusion? For sure. CT perfusion is enough, and with CT angio, that is more than enough. MRI essentially takes time. You have to evaluate for the presence of any sort of metal, etc. and stuff. The MRI scanners are not available that frequently also in the hospitals, but you don't need anything beyond the CT, because our job is to look at the infarct. Our job is to look at the clot, and our job is also to look into the perfusion mismatch. So if there is no mismatch, absolutely fine. So MRI is anyways very rarely performed as an acute stroke protocol.
Thank you, Dr. Sweta. That was my professor of radiology, Dr. Limos, Dr. Raul Limos from Philippines, Angeles University.
Oh, perfect. Dr. Raul, yes. And this is the reality, right, Dr. Unni? Because
Yes,
most
yes.
of the tier 2 and tier 3 would not have an MRI, and there's no this about making everything complex. I think simple CT perfusion and added CT angio head and neck should be enough for any clinician. We are not just talking neurologist. I think any clinician, because by the time the patient is shifted back and forth, we've already lost the potential for thrombolysis. Despite having all this, the rates of thrombolysis is dismally low, and I think that's why the outcomes are also not that favorable.
That is the true scenario in even in India and also in the Philippines. Hussein, can you unmute Dr. Raul?
Sure.
We can hear from him because he is the head of the department radiology. He will have a first insight on the department is very close to the emergency room. So
Yes, I have unmuted. Yeah.
Good evening to all.
good evening, Dr. Limos.
Yeah, good evening to all. We just do CT perfusion for our acute stroke patients. So I asked that question of whether to do a CT angio or CT perfusion. So we just do CT angio or CT perfusion. It depends on the radiologist on duty at that time.
See, that is also one concern which we see in most of the hospitals where you do not sometimes have a full-time senior radiologist on duty. That is where the decision making is delayed. The radiologist has to travel, or head of the department has to take a foot and say that, yes, I would like to do it as a priority to make a clinical decision more wise to save the patients. Again, as I say, as Dr. Sweta has pointed out, my tissue time, I have to save the tissue. Yeah.
That's exactly where also AI comes into play, right? So this is where, if there is a software-backed analysis which can help the clinician in deciding the the penumbra or the core infarct with the simple CT perfusion, because you don't want to complexly understand the CT perfusion. You just want to know what is it, the moral of the story, so to speak. That's where I think AI and these technologies can be of super help.
Right, Dr. Sweta. Actually, with NeuroShield, we are actually working and will be working on identifying the ischemic core, identifying the penumbra, identifying the normal tissue, which will help us to again quantify the core volume of the infarct, the penumbra. And also, you pointed out the importance of having the collateral vessels. Also helps you physicians also to make a decision more precise when it goes into more invasive or non-invasive process. That is, yes, priority, and we look forward to work on that alongside the practicing physicians who are seeing such cases day in, day out. Dr. Sweta.
And also, Dr. Unni, just to add to that is hemorrhages, right? I did not talk about hemorrhages in the current but identifying the volume, what could
Yes.
be the potential etiology for such hemorrhages, whether there's a midline shift, etc. I think these are the things which AI facilitates pretty accurately. And even if there is no radiologist who is available on site, the clinician can get a very detailed review about it immediately, pretty much.
Yes, yes, Dr. Sweta. Hussein, do you have any more questions?
Yes, one final question, very interesting one at that. Do patients tolerate ischemia differently for various reasons, or when we are looking at this particular topic, time is one variable, and we are saying tissue is one variable. Are there any other variables which differentiate one individual from another?
Oh, lots of variables, right? I think the past history, the age of the brain, the blood pressure on presentation, the proximal vessels, the cardiac endurance of the person. So many factors are there when it comes to the outcome. No single factor is sort of, uniformly deciding. But yes, reperfusion has been one of the factors which determines a very solid outcome. As I pointed out, 33% less chances of being crippled or handicapped. So I think this is a very important factor. But overall, from the point of view of the stroke, it is always a multidisciplinary care. Nobody can say that physiotherapy is not important or management of blood pressure, sugar is not important. All this added together as a multidisciplinary team can only make a difference in patient with a stroke. And I think one good thing is slowly the thrombolysis rates are improving, the multidisciplinary care setup is being done, people awareness of reaching on time is getting better and better. TIAs are also equally important. If there is a motor TIA or a limb TIA with weakness, this is the chance that a person can get a stroke within the first week is very high. People are coming to the hospital, and this is, I think we, all of us have to reinforce into the community the same message again and again, time and again. What do you say, Dr. Unni, to that?
Very nice point, Dr. Sweta. I totally agree. We have spoken about stroke as per se, clinical presentation, imaging. This is after the event has happened, and post-stroke, there's a whole world of practice which is lying. But I have a different perspective look. I have been also working on some research in how do we pre-identify a possibility or a probability of a person to have a stroke, possibility of having a stroke. So we have been clinically always looking at imaging when we are looking at all the bigger blood vessels like your circle of Willis and up to level 3, level 4 of the blood. But the early changes usually happens at the microvascular level, both all in 3 different organs, your brain, your heart, and your kidneys, wherein all these microvascular insults which are happening usually goes unnoticed. We would do a screening, and screening is normal. A patient would be presenting to you as with a simple headache, and it might not show up other than if the doctor is not going through a full-fledged diagnostic imaging study, like more precise diffusion weight imaging and more of advanced stroke protocols on the latest 3 Tesla MRs. Otherwise, we are missing on how do we screen. So I have been working with the team of optometrists and ophthalmologists, wherein we were looking at early retinal changes, which is the only blood vessel which can be seen virtually and in comparison to the same size in the brain, the heart, and also in the kidneys. We should be able to see early arteriovenous nicking. We should be able to see early arterial narrowing. We should be able to see minor or very early occlusion or the emboli of the arteriolar emboli, which should be identified very early. And I think, and I am a strong believer that it would help physicians prevent a stroke as an event which would change the life of a patient? Dr. Sweta.
Absolutely, Dr. Uni. I think I'm just going to refer to the Google new algorithm, which has predicted based on the retinal vasculature, what you are just narrating, that about 300,000, which is a very robust
Yes,
data, that
please.
we can detect heart diseases or strokes, essentially looking at what the blood vessels are in the retina or even in the anterior chamber of the eye.
Yes.
So definitely this is the future. I think very important, again, going back to this old school of thought that you don't want to douse a fire, essentially, when the stroke has already happened,
Yes.
but prevention is always better
Yes,
than cure.
yes,
So
yes.
the old is essentially still the same gold.
Yes, yes, Dr. Sweta. Wonderful. Hussein, do you have any more questions?
We have one question about cerebral reserve and what is the importance of identifying this and the implications of it on the treatment for a stroke patient.
It's essentially the same what we discussed, right? It's collateral. So your cerebral reserve, also there are two types of reserve when we talk about vascular reserve and itself the tissue reserve. So if there is a very large infarct where you don't have much of the other tissue reserve, so the recovery can be impacted. And exactly the same thing if there are multiple clots or multiple atherovascular disease with multi-vessel blocks, then obviously your reserve is going to be bad, in which case even despite the thrombolysis, the outcome is not going to be robust. So all these, again, factors, the age of the brain, the type of the brain, the blood flow within the vessels beyond the culprit vessel. So if there is an MCA which is blocked, but if my ACA is not giving me enough perfusion, or if my any other vessel in the circle of Willis is affected or carotid is affected, that means that my cerebral reserve is not going to be enough for me to determine the type of the recovery that I need.
Thank you, Doctor, for your insights in this particular topic. With this, if there aren't any other questions from the audience, we come to the end of today's session. And on behalf of the entire InMed team and all the panelists, we thank you for compressing your decades of experience, Dr. Sweta and Dr. Unni, and sharing it with us. And we look forward to hearing you on another one of our webinars on neuroimaging very soon.
Absolute pleasure, Hussein. Thank you, Dr. Unni, for being a fantastic panelist, and thank you to everybody who has been so inquisitive. Thank you, InMed, as well.
Thank you, Dr. Sweta. Thank you, Hussein.
Thank you, everyone. A YouTube recording of this webinar will be sent to you and all of the webinars that we have hosted previously. And see you next time. Good night, everyone.